pediatric hospitalist. I've been here about 4 years. Generally, my experience with you guys is we go to the deliveries and we'll go over criteria, some of the criteria for deliveries we get called to.
Can you tell us when you went to med school and where you trained?
Yes. So I'm from Israel originally, but my mom's from New York, so I speak perfect English. I went to Tel Aviv University, School of Medicine, and I did my residency at Einstein in New York, and then went back to Israel actually, and eventually came back here. So my wife, who also went to med school, is from Israel and could do her residency in OB. So she was at the Fresno, UCSF Fresno program. And so I lived in Fresno actually for 4 years. and that's it. So I have a little bit of a lens into the into OB life, OB resident life. We had our second child there while she was a resident. That was fun. So that's it. So it's been really fun here. I've been here 3.5 years, and it's been a great collaboration between the two departments, definitely. So it's a little bit like of an informal thing. We're not doing NRP course, but we're going to do an NRP talk. Feel free to ask any questions, just raise your hand, anything that's not clear. I have no disclosures, and with that, we'll get started. So NRP, the set comes out, the new guidelines, which are supported by the American Heart and the AAP, come out about every 5 to 6 years. So the 7th edition came out in 2015, and there were some modifications made about 2 years later. We'll go over that. The main thing for people who've been practicing for a while know probably the biggest change with the new NRP edition is how we deal with babies that have meconium. So in the past, we used to intubate, suction all babies who were born who had when there was meconium stained fluid, and then we moved to don't stimulate the baby, let's suction if the baby doesn't cry spontaneously, and then we moved to just treat them like normal babies. So now, if you have a baby who has meconium, let's say in the mouth and it's all over the face, we do want to just do bulb suction, because that first breath you want to just clear out the mouth and theirs as much as you can, but then go ahead and do good effective stimulation and get the baby to cry. That's probably the biggest change with the last edition. So this is what we go by. 2015 algorithm hasn't changed too much. It's a little bit more, I guess you could say, flexible in terms of, let's see, oh, sorry, there's, it used to be like every 30 seconds you have to do something. Right now, with the new guideline, they basically say you have a minute to decide whether or not you need to give the baby PPV. Yeah.
For anybody who is paying attention to this talk on Zoom, they might not be able to follow along with anything you're doing.
Oh, that's true. Yeah, so let's see. Can you see?
If it doesn't work, then that's okay.
Okay, so I'll just point and describe. So if you go to the 5th line down, we have our criteria for giving PPV. So you guys are probably familiar with babies that require positive pressure ventilation because they're apneic, but another criteria is if the heart rate is below 100. So that's something that we keep in mind when we're checking the heart rate. Those two things usually go together. So if a baby is gasping or doesn't have good respirations, typically their heart rate will start to drift down and it will end up below 100. But sometimes you get these irregular breaths. You might notice that. The baby comes out, has like one breath, and then it's sort of quiet, and you stimulate, has another little breath, and it's irregular, and the tone isn't great. Chances are the heart rate is below 100. That's when we want to intervene. And so, do you guys remember what we call that when a baby goes apneic after a couple of irregular breaths? What type of apnea that is? So it is central, but we have, we call it secondary apnea. So in the first place, the baby comes out, they have primary apnea. They should respond to stimulation. If they don't respond, or they do and then they don't, it's secondary, and that's when it's time to bag the baby. So if there's one takeaway from this entire NRP thing, and they say this in the NRP handbook and in the tests, there's a test recently that I saw. It was like a 24 question exam, and 4 of the questions asked the same thing in a different way. They really stress this. The single most important intervention you can do to a baby who is depressed is ventilate. So they want to just stress this, not blow-by oxygen, not CPAP. You have to actually give positive pressure ventilation breaths. Okay, and 99% of the time, this will get the trick done, and the babies will start crying spontaneously.
So you ventilate with a mask?
Ventilate with a mask.
And a little mask.
Yep, just bagging with the mask. And we're gonna go over all that, but and I'll show pictures of masks and proper ventilation technique. But that's the one thing that is kind of the big takeaway with NRP.
And Nala, what's better for the baby to have primary apnea or secondary?
Well, primary they all have. Like initially, babies come out and they're apneic, and then you stimulate, and they just start crying.
Right.
So that's normal physiology. Secondary apnea will not respond to stimulation. So that's very important to just keep in mind. If the baby is not responding to stimulation, they will respond to positive pressure ventilation. They need that oxygen delivered to the brain so their respiratory drive can work. So just keep that in mind. Like, it's not a big deal. It looks very scary most of the time. Now, occasionally babies don't breathe on their own. We end up needing to intubate and doing the whole 9. But like I said, 99% of the time, they just need positive pressure ventilation. The sooner they get that, the better your gas is going to be, the better the outcome is going to be. The more delayed, then usually not as good outcome. So we want to initiate UV sooner rather than later. Sorry?
Hey, it's Christina. We were just wondering if you could repeat questions that are asked so that we can know what they're on the speaker.
Oh yeah, just we were talking about the distinction between primary and secondary apnea, and I just was describing the that normal physiology, primary apnea, baby would respond to stim, whereas secondary they don't.
Yeah, we were just wondering when the audience asked the question if you could repeat what they asked.
Oh sure, okay.
I have a question.
Yeah.
It's sort of related, but prior to the baby being born,
Yeah.
mom is in labor and there's T cells. Is stimulation during a T cell helpful or not? Because I've heard 2 different things about, like, if you can reach the scalp and do scalp stimulation during a T cell, is that helpful?
So in general, I can just answer you theoretically because I don't think it's been studied necessarily. But oh, I'm sorry. Thank you. The question was, would stimulation prior to birth, when a baby has D cells, would that help? That was the question. So in general, if there is a cutoff to circulation, that's usually the cause of the D cell. And so stimulation is designed to stimulate, not cause too much pain, but stimulate the baby to cry essentially and then breathe as a consequence. So I don't think that it would follow the same like logic. Interesting question. So that's where, this is our kind of the crux. I mentioned it once again, the PPV, that juncture in the first minute of life, when to start positive pressure ventilation. Now, there is like a sequence, as you guys know, like your first steps, which initially you dry, warm, stimulate, and then you look for a response. You go to PPV. If you keep going down the algorithm here, ultimately, if your heart rate remains below 100, or you don't have good respirations, you consider putting a definitive airway, intubating, and ultimately, if your heart rate is below 60, you actually have to start chest compressions, put in a umbilical line, and give medications if no response to compressions. We'll go through that a little bit. Another part of, if you look in the right lower corner, we have our targeted SAT flow sheet. This is also a new part of the latest NRP 2015, which basically aimed to decrease the amount of oxygen we give babies unnecessarily. So this is our minimum sort of target oxygen saturation. You can see at 1 minute, the baby's still blue actually centrally. So, and that's normal, 60 to 65, and it goes up by about 5 every minute until the baby becomes pink by 5 minutes, which is usually when you go past 80% sat, they should look centrally pink. Okay, so here again is our sort of sequence of events from the least intervention to the most, what we mentioned. And then who goes to, when do we go to delivery? When does the NICU team come to deliveries? So these are just some of the examples. If we suspect fetal distress, based on your tracing, or if there's a history, an abruption, or suspected abruption, or any other fetal distress that you guys can think of. Preterm infants under 36, if it's emergent operative delivery, if there's meconium, any anomalies that we know for sure will require NICU admission. So example would be like a diaphragmatic hernia, gastroschisis, certain heart defects, and so on. So those are some of the examples, but you can call us for anything. We'll always have you come. So the question, hopefully we can answer with this talk, and you guys will be able to answer, is which babies need intervention? Who needs resuscitation? And so we talked a little bit about how we get to needing positive pressure ventilation. And just stepping back to the algorithm, which baby, what are the two, do you guys remember what were the two criteria for giving positive pressure ventilation? And what's the other one? Apnea or gasping respirations. So, and so how do we get there? How do we get to this secondary apnea? Well, there are many different reasons. It could be that the baby we thought the baby was crying well, but it just cried once and then stopped crying, needed like more stimulation. Could be that we did do stimulation, but the stimulation was inadequate. And it's in a later slide, but do you guys remember? Because every time I give the talk, I always mention my favorite stimulation method. But do I? Don't pull the baby upside down, slap the butt. No. So it's on the back, and it's rubbing your fingers like along the spine. So really, like, if you can feel those spinous processes while you're stimulating, you're doing it the right way. Now, NRP says gentle stimulation to the the spine, along the spine, or flicking the feet. Flicking the feet means you probably have to like hold the foot with one hand, flick with the other, but usually you're busy with one hand. So it's a one-handed thing where all you need to do is just run your fingers along the spine. They say gentle. Now, I sort of think they mean don't like shake the baby when they say that, but I don't think they mean like do it so gently that they can barely feel it. Like I think it has to be firm, but you know, yeah, I mean, and even if you, yeah, so
Is
if
that
you,
big study, like is evidence based or is experience?
for me, I'm speaking from experience and I haven't seen any studies on stimulation, but we used to have other forms of stimulation, and I think this is the safe. These two are the safest as far as like American Heart and AAP are concerned. So you obviously don't want to do anything that ends up like moving the baby or shaking. So the spine, I've found it to be like pretty effective. So you'll always see me like do this in the C-section or when I go to the delivery room. If I don't hear the baby crying like continuously, then I'll just go do that. But you could do adequate stimulation, and then you get to the third part here, which is what if your airway is not patent? So, so if you have a hyperflex or hyperextended, babies have such small airways that the slightest bit of hyperextension or flexion can cause kinking and occlusion of the airway. Also, the airway is so small that any secretions can prevent oxygen from going through, adequate from going through. And so even if you stimulate adequately, that baby wants to cry, but they don't have a patent airway. So make sure position is very important. And we'll go through that a little bit as well, a little bit later too. I mean, I've seen, you guys have probably noticed, like baby comes out, congratulations, and they just get put like face down on the mouth. You know, so you need the mouth, you know,
Not in a booth.
not, yeah, and the stimulation. You have to have both position and stimulation. So I'll show you a little bit of what the sniffing position looks like and clear any secretions like we mentioned earlier. Always be prepared and ask these questions in your initial assessment. Is the baby breathing or crying? Do they have tone that's now like starting to improve? A little hint you might notice, you might have already noticed it to going to secondary apnea. If the baby is completely limp, they cry a little bit, and you see that they are completely like a wet rag, keep in mind they might be going to secondary apnea. Those two things often go together, tone and breathing. So just keep that in mind. And then what about color? Is color a good way to assess how the baby's doing? Not really, because I showed you the flow sheet earlier. So this is a perfect baby at birth with central cyanosis, completely normal. There are also some things you can see on the slide that can be a little bit misleading. So if you look at the right lower, you look at the face and it looks kind of blue all over, but you see a baby has great tone. It's actually pink here. So what's this called? On the face, when the face is blue like that, and the baby, maybe she had failure to progress and she was stuck for a while. Bruising or venous stasis, yeah. Facial bruising or venous stasis we call it, and I always explain this to the parents physiologically, because when they say, oh yeah, baby was down there for a while, and they're like, because I usually tell them that's the reason, and then they always say, oh yeah, he was down there. And the way you kind of, if you weren't sure, you just get an O2 sat, and it would be 100%, and that would convince everybody. But when you see this, if you want to also reassure yourself, you can look at the gum line, and the gums should be pink actually. The bruising is only on the skin, at the skin level. So I always lift up the upper lip and I look at the gums, and they're usually very pink. You can also have acrocyanosis. You can see this can last for a couple of days. So that's nothing to be too concerned about even after a day or two. And again, here's a little bit of venous stasis. We talked about the O2 sat nomogram, the target, what we call target sats. I don't really like the fact that they use the targeted sats because that makes it sound like you should strive for these numbers. But the truth is that it's usually in the 90s by 2 to 3 minutes, the O2 sat is. Okay. How do we deliver oxygen? Typically, we start at 21%. So the picture of the dial you see there will usually be at 21. Starting with the term baby, preterm, we start at 30%. And always try to clear secretions before you give PPV. Start with the mouth and then with the nares. We use our pulse oximetry to help us guide how much oxygen to give based on that nomogram you saw. And then once again, the first steps is just the same algorithm I showed you earlier. And this is a pretty good, maybe one of the more relevant slides for you guys. So when you're trying to do everything you can correctly to get the baby to cry after birth, this is one of them. So you want to make sure that you have a good sniffing position, and that would be the upper picture. And so a common thing is probably more than hyperextension. I see very commonly babies hyperflex. They're just kind of scrunched up in that fetal position or whatever, when they came out, which is not great for opening the airway. So you want to be a little bit extended, what we call the sniffing position. And it helps, you can see in the picture here, to put like a shoulder roll or even just like your hand underneath as you're stimulating. Routine suctioning is not recommended anymore. It used to be. So just if there's secretions, what happens when you suction routinely is you end up inducing a vagal response and babies can become apneic, bradycardic. So especially, I don't like to suction like straight down into the posterior pharynx. I usually like put the head sideways and like suction secretions out that way.
I feel like for the most part, we hand the bolt to the nurse and they may or may not like start suctioning with like probably 30 seconds.
Yeah.
Is there like, should we try to assess a little bit longer before we're like trying to do something?
Yeah, it's a good question. So the question was, should we intervene or is there a time in which we should encourage the nurses to suction or not? I guess like the nurses who work with you guys should all be NRP certified. So they should actually be trained on when to suction, when not. I haven't seen too many issues. In C-sections, I noticed, they're distracted, they're doing their thing. But we're there, so usually, but yeah, they should know when to do it. And it's usually when there's a mouthful of secretion. So here's the type of stimulation. So types of stimulation are the two recommended are in the NRP manual are flicking the feet or rubbing the back. And so you guys can, over time, you'll probably notice your favorite method, like you'll see what works. But yeah, I like the rubbing the back. There's two main ways we use to assess the heart rate on physical exam, which is palpating the stump of the cord and auscultation. Auscultation is more foolproof. Palpation is a little bit harder at times, especially if you have a poorly perfused baby. So which is exactly the babies that you end up checking the heart rate because you want to know where you're at. So typically when babies are down and they need intervention, I just auscultate. And then we put on now, we started putting on EKG leads, especially when we know there's going to be distress. We bring EKG and put the leads on, a 3-lead EKG, so we can get an immediate and continuous heart rate monitoring. Yeah.
Should we take a longer stump?
That's a good question. So if we think the baby is gonna come to the NICU, it's a good idea to do. We don't need more than like an inch. Yeah, because typically we cut it at half an inch. So the question is, should we leave a longer umbilical stump? So primary and secondary apnea look exactly the same. There's no breathing, but we explained earlier how they evolve. These are the different masks that we use. There's the round one, you tend to just push down and it kind of becomes this sort of pointy thing, more of like a football shape once it curves around the mouth. The ones with the V shape on top obviously goes over the nose. It's important to get the right size mask, I think is the point of the slide, just so that you get a good seal, because getting a good seal, which we'll go through in a second, is important to giving effective positive pressure ventilation. Okay. So we have, let me see, sorry. We have 3 different types of devices we use for positive pressure ventilation. We have the anesthesia bag, which is this one, also called the flow inflating bag. We have the self-inflating bag, and we also have our T-piece, which the main things to know about those 3 devices is that you cannot give free flow oxygen through the mask of a self-inflating bag. But with an anesthesia bag, if you want to just give blow-by oxygen, you can do that, and you can also do it with a T-piece. You can also do CPAP with those 2 bags, the flow inflating and the T-piece. So this bag, the self-inflating, you'll never really see in delivery room or like as a standard. It's something we take on transport because you don't need like a flow device. You don't need a source of oxygen flow to actually deliver breaths, whereas the other 2, if you don't have flow, you can't give breaths. This is the T-piece that I mentioned. And so how many breaths per minute do we give? It's typically, an easy way to remember it is about 1 breath per second. So it's totally different than adults, which is like 1 breath every 5 seconds or so. This is you're giving, you basically counting like breathe 2, 3, breathe 2, 3. And when I say that, the reason I'm saying that we do it that way is because you actually need about an I time, which is the inhalation, of about 1/3 of a second. So you're actually delivering a breath and give about 2/3 of a second for them to exhale, and then give a breath again. So every second you're doing breathe 2, 3. So you want to actually remember to let go of your breath after that breathe. That when you say breathe, breathe and then let go and wait for exhalation. So this is probably one of the most common mistakes that I see done by RTs, especially if they work on the adult side when we're doing resuscitations. When we're giving PPV, I always say this, and it sounds funny while we're in, you might hear me like in the delivery, at the warmer, like saying, okay, breathe 2, 3, breathe 2, 3. I'm actually like telling them how fast I want them to do it. And it really makes a big difference. If you are not getting a response, typically our algorithm says you want to monitor for response after 15 to 30 seconds of PPV. So let's say you have an apneic baby, you have a heart rate that's below 100, and you started giving positive pressure ventilation, and you're not getting a response, your heart rate's still 80. That's when you start troubleshooting. It's called Mr. SOPA. So effective ventilation will include all these things. You want to adjust your mask, get a good seal, reposition the airway. What position? Do you guys remember? The sniffing position, exactly. So you get the airway now because maybe the baby's very, believe it or not, people do this all the time. When the baby's blue with a heart rate of 60, it's very common to just be, you're like anxious and you just put the bag on, you just start bagging. And you'll have a kinked hyperflex neck and everything is like not in the good. So you really have to focus on that, and the seal won't be good because you just want to start doing something. But you have to really like take a step back, put the airway in sniffing position, get a good seal. And then the other thing, number 3 on the list there, is make sure that you suction out any secretions and make sure the mouth is open. Once you've done all that, if you still don't have a good response, what I do, and it's not on the list, is I crank up the oxygen. So if I started delivering 21%, if there are a lot of let's say there's secretions further down, and I'm just giving breaths. If 21% oxygen or 30% on a preterm baby is not getting through, well, if I turn it up to 80 or 100%, even if I'm not that effective, I'm probably going to deliver oxygen to the brain. So I turn up the oxygen. You can also increase the pressure, and that's your PIP. Does anyone remember the pressure actually, you don't need to remember. No reason you should remember this, but the PIP on babies is something we dial to about 20, and the PEEP is 5. So we usually say 20/5. You can turn the pressure up to 25 or 30, the PIP, if you still don't have a response. And then finally, alternate airway would be intubation. Or laryngeal mask airway, an LMA. And so if you still don't get a response, and this is very rare, thankfully we don't see this very often, you still have a heart that's drifting, heart rate drifting down, and now it's below 60, despite having, despite having good effective ventilation. Notice the second box here says intubate if not already done. So they don't want you to do chest compressions while giving PPV. Like they want you to actually, with a mask, they actually want you to intubate and make sure you've done everything possible to adequately ventilate that baby before you start going into resuscitation mode with chest compressions and medications, because the chances are your whole heart rate problem is related to inadequate ventilation. That's why this is so rare, having to do medications and chest compressions. So once you start chest compressions, if that's ineffective, then you go to the last box, which is starting medications with epinephrine. So what are your landmarks for chest compressions? Just below the nipple line. And you can use the 2-finger method and go down about 1/3 of the depth of the chest. Chest compressions, once you have a definitive airway, are given at a 3-to-1 ratio with breaths. So it's, we count it out as 1 and 2 and 3 and breathe. And that happens every 2 seconds. So it's basically 120, what you call 120 events, or 90 compressions and 30 breaths per minute. So the breaths are a little bit less than before. Remember I said it's about 1 per second. When you're doing it with CPR, with compressions, you're actually only giving 30 breaths. And this is a example of the 2-person technique where the RT or whoever is ventilating is at the head of the bed and compression's happening below. This is the other method with a 2-finger. And so APGAR scores, you guys all know about. I think the main reason I put this here is because APGAR scores do not determine anything with regards to NRP or resuscitation. It's purely just like a documentation thing that has some, but not really any concrete, I think, inference on prognosis, but it's used for somewhat for prognostication. Doesn't affect our NRP. Any questions about this? Back to our algorithm, back to our flow sheet. Yeah, sorry.
Should we continue to use the APGAR scores given that the color, as you said so much against the color?
So the question is, should we continue to use APGAR scores, even though the color doesn't really tell us much as far as like how well or not well the baby's doing? I think APGAR scores are helpful if you know what the score is given for. So if the score is given for tone, like neurological status, that's helpful for me. But if someone tells me that the score was an 8, I really have to know like why it was an 8. Like I have to know, is it 2 off for color, or is it 1 off for color, 1 off for tone? Or if it was a 7, it makes a big difference to me, you know, what those numbers are given for. Like, is that for a low heart rate and maybe tone? Or what is it? So whenever I see APGAR score, I always try to find, like, if it's low, I always try to find what they gave it for. I think it is useful, because if it's a 9 and 9, then that helps us. When it's low, we have to look for more details, I think. Okay, so we're basically almost done here. I want to just give you the take home, since we work together a lot, from the things that I would stress and what what we can continue to work on. So positioning the baby is key. I think when the baby comes out and you stimulate effectively. So you have to do both. You have to position the baby and stimulate effectively, and suction when needed. This will probably avoid a lot of secondary apnea, just those 2 things alone. So keep that in mind. I know we're like very distracted, but those 2 things, position the baby, stimulate effectively, and that means rubbing well along the spinous processes. If you see that there is an irregular or absent respiratory effort, do it again. Just position the baby and try to stimulate effectively. Get out any secretions if you notice them. If there's still no response, and now let's say 30 seconds have gone by, 15 to 30 seconds, and you've done it 2 or 3 times, position, you suction, you stimulated, just call the NICU. And when you do that, ask the nurse to take the baby to the warmer and start PPV. And or you can say something like, if the baby's not crying with stimulation and you don't see breaths, start PPV or start ventilating with the bag before NICU team gets here. Because that 1 or 2 minutes until we get there can, affect outcome. We're always available. And so actually, some people don't like it. I actually don't mind if I come and you guys say, baby's fine, everything's great. It's great, So don't hesitate. Okay, so some frequently asked questions and comments. There was a slide on this earlier, but I took it out because I just want to leave it as like a frequently asked or a hot topic. Here at Valley Med, we do 3 minutes of DCC. If the correct conditions are met. So So what are some things that we would abort delayed cord clamping for? Any thoughts on that? Exactly. So if the baby doesn't look good, if the baby's depressed, it's time to bag the baby. So that extra, few red cells are not going to help a baby if they are not adequately oxygenating. So anything else? Think of maternal distress, unstable mom. There's no point in doing it. Right, exactly. So if blood's not going to go to the baby, you have an abruption. I think those are the main ones. But if all conditions are met, then we should do delayed cord clamping for the time being. It's 3 minutes here. NRP specifically, the new edition, and this is another thing. So now I gave you 3 new things from the 2015. They recommended delayed cord clamping for a minimum of 30 to 60 seconds. So they want you to do at least a minute whenever conditions are good, and we do a little bit more, or a lot more depending. You asked, what's that?
I was going to ask you to comment on cord milking.
Cord milking, yeah. So that's a very good, so the question was to comment about cord milking. So milking the cord, and you guys were all trained on this, is something that can be done if also conditions are good. So if things are too unstable, don't worry about it. But if you can spare those few seconds to milk the cord, even a couple times to just deliver a little bit more blood to the baby, if it's a preterm baby, it could potentially avoid blood transfusion. There's also some studies on pretermers that show cognitive benefits for a little bit more red cell delivery. The one thing I'll say about milking the cord, if you could just remind the new people, it's not supposed to be done very quickly because you can change blood pressure. You can change blood pressure levels rapidly, which could be a risk for IBH. So just keep in mind when you milk, it's like a gradual thing. You're not like pushing it as quickly as you can. So just kind of do it like gradually.
Mostly the setting.
Nadav?
Yeah.
Can we also add on some more things to DCC? Can we?
Yeah.
Yeah, I think so. The main benefits of DCC in the very preterm infants is a reduction in mortality by 30% if you get at least 1 minute DCC. And that's based on large randomized control trials from Australia and from meta-analysis of all RCTs. The preterm infants also benefit by having reduced IBH, late onset sepsis, and necrotizing enterocolitis. What we have seen is also further reduction in intubation with longer duration of DCC with preterm babies. So preterm babies, we would give them at least the first minute to see how well they're breathing, because even when they're not vigorously breathing, they have these very subtle breathing motions. And we know that for 95% of the small babies will take their first breath before 55 seconds from, again, another RCT that looks at milking and doing resuscitation while a baby is born. So the preterm babies have big benefits in terms of morbidities. And then the term babies, the studies, the less than 29 weekers, so the milking typically, if you can get DCC, that's our first option because that's the most physiological, the 3 minutes. If you cannot get the full 3 minutes DCC, then we would request you to milk, and that's the gradual milking that Nadav explained times 4. If you have to abort DCC, say because of maternal bleeding, or we feel like we need to clamp and get the baby out. If it's less than 29 weeks, we do not want milking because of one RCT that showed increase in severe IVH in the small babies.
Under 29, we don't know.
Yeah, and then the term baby studies have all done 3 to 5 minutes is the duration of DCC, which have shown increased myelination in the MRI studies in the brain, improved anemia rate, reduced lead toxicity. And then one study also has shown that with 5 minutes DCC, there is an improvement in the IQ level, especially in boys. So there is a lot of, go ahead.
Was that the preterm study, the IQ one?
That's the term study.
Term study, okay.
Yeah. Mm-hmm. So the babies do have a lot of benefit, and I think we've felt at least the first minute, because even with NRP, your guidance is to stimulate and oral suction, which you can do. So the first minute, we want to see if the baby gets, you can actually start having the breath. And if not, beyond 1 minute, if the baby remains apneic, then we would clamp the cord. If you're not too small, we would ask for milking and then clamping the cord. And of course, it's for maternal indication, it's mainly bleeding, and that's really whatever the OBs at the time of delivery, what they can see, will guide us on that.
So thanks, Priya. Also, just add on to our assessment of the newborn at the time. One other thing that helps us figure out whether the newborn can continue DCC is also the heart rate. If we're not sure about respirations. So that's another thing. If we notice the heart rate is drifting down, we might ask to abort. The other thing also, Priya, since you're here, about the DCC in all conditions, NRP recommends to use a warm, to dry the baby and keep them in a warm blanket during the DCC, which is something I think probably there's room for improvement on. Like we could work on that a little bit to avoid, cold stress. So whenever we have warm blankets available, we should really use those while we're doing this. Alternatively, if it's a vaginal delivery, then we can just have the baby skin to skin. So those are your two options: is either skin to skin or keep the baby in a warm blanket.
Yeah.
Yeah. Sorry. Go ahead.
And we've been trying to include some comment about diversity and outcomes, black babies, colored babies. Can you make a comment on that?
Priya, do you have any comments about? I know we have some initiatives, but do you have any comments on racial disparities with regard to outcome?
So all our NICU data are benchmarked based on race, ethnicity. What we do know is, we don't have a large population of black babies. Majority of our babies are Hispanic. We haven't, in our institution, based on our last 3 years data, the main areas of disparity that we have noticed is in the respiratory outcomes, which is specifically RDS and pneumothorax. What we've noticed is in the non-Hispanic whites, there is a higher rate of pneumothorax from our institution. Majority of our babies are Hispanic white babies. And we don't have a big disparity. In terms of breast milk feeding at the time of discharge, again, no big difference based on race, ethnicity for our institution. One of the possible reasons in that situation, again, is the majority of we don't have a lot of Caucasian babies or black babies. The few Caucasian babies that we do have, unfortunately, there is a higher rate of substance exposure. So, in what context of outcome? In any outcome. So I'm assuming the question is about any neonatal outcome, right, based on race, ethnicity, yeah. So that's all we have, and this is, and other major morbidities, we don't see a big difference based on race for our institution.
Great.
So in general, blacks.
The data from outside, what we do know is there is a higher mortality for Black babies.
Yeah.
More than twofold increase. And then there are other major morbidities that are also worse in Black babies. Does that answer Dr. Hamlet's question?
Yes, it does. Thank you.
Okay, so we, the second item there is if we could just try to remember to give adequate lead time for the NICU team. This is especially true, and I don't think it's been an issue really with our preterm deliveries where we actually have to assemble a team of 2 providers, and it's more complex, what we call a smart start. But if you could, what I've noticed is the OR calls are very often borderline. And just because we have a little bit more, we actually have to gown, glove, and get the history. If I'm going to a vaginal delivery, I can just walk in, put on gloves, and immediately start potentially resuscitation. But the OR can be a little bit, can take us a little bit more time. So if you can just remember, maybe add like 1 minute to what you've normally been doing, I think can be helpful.
For reference, about how long does it take for you to get to the OR from the time you hear the call?
It can take, I would say 1 or 2 minutes, depending on the time of day. So if this is like at 2 a.m. Or 3, I mean, potentially we could have 1 person up on pediatrics, so then we only have 1 person in the call room, and so they have to physically, like you're already in the OR, you're already cutting, but we might be like in deep like REM sleep, and so we have to actually have to wake up, we have to put on our shoes, get out of the room, get used to the light, walk out. You have to like show up, so remember where you are, you know, and so then by the time you get there and you're gloving and gowned, like it might actually be like at least a couple minutes. Yeah.
Or you could be in the middle of a procedure.
The what?
Or you could be in the middle of a procedure
Or
too.
you could be in the middle of procedure. And typically if you're, I would say that's true. And you can be in the middle of procedure if you're, usually we try to like account for that with like, let someone know, hey, I'm doing a procedure. If you could be back up while I'm doing this, but that might not be the case either. If it's an emergency procedure and so we could be resuscitating another baby in the NICU. But those are like, we usually have at least 1 of us available to go to delivery either way. So I would say from my experience, I usually get there before the baby's out, but sometimes I'm still not, I don't have my gown on. So I would like add a little bit of time.
Should we let you know when we are about to scrap for a C-section?
You can do an FYI to like just call the unit. We're about to scrub for. I mean, that could be helpful. We usually know when it's during the day. It's the night ones where, yeah. But yeah, 2 minutes. We should definitely be there and ready. So I think that's enough lead time. I think that's basically it. Any other questions, comments? You guys learned something?